Hello, and thanks for coming to my virtual poster presentation. My name is Jamie Song, and I'm presenting my MPH capstone research today that I completed under the mentorship of Dr. Gina South, Sarah Solomon, and Dr. Doug Weeb at Penn. The title of our study is called Structural Injustices and Pandemic Vulnerabilities, a spatial statistical analysis of social vulnerability and COVID-19 outcomes in the US. Let's start with some background. The COVID-19 pandemic has made existing health inequities worse around the world, and especially in highly impacted countries like the US. It has disproportionately burdened the most marginalized communities, those that have borne the brunt of racism and white supremacy, capitalism and economic domination, and other dimensions of structural violence embedded in US society. We embarked on this study after seeing extensive coverage of individual risk factors for COVID-19, but little analysis of place-based risk. And those that did focus on place-based factors tended to focus on individual variables such as poverty and racial demographics. Here, we use a composite measure from the CDC called the Social Vulnerability Index, or SVI. Initially developed to identify communities most at risk of high impact in emergencies and disaster events, SVI assesses forms of historical marginalization and demographic vulnerability. On to the objectives. In this study, we examined the associations between the SVI and COVID-19 outcome variables, namely cumulative incidence, or CI, and case fatality risk, or CFR, at the county level within the continental US. Validating the use of SVI to understand sources of critical health inequities can provide support for its use as a public health tool, including the use of SVI to guide allocation of COVID-19 vaccination efforts. To talk a bit about our main methods, we ran something called optimized hotspot analysis to identify areas of high CI and CFR at a 95% confidence level across US counties. And we used the logistic regression models with covariates to study the relationships between SVI and hotspot status for both CI and CFR. This first map shows the distribution of CI across US counties in a white to black color gradient, as well as the hotspot analysis result in teal. The middle map similarly shows the distribution of CFR, and the hotspot analysis result is in orange. In this final map, we superimpose the hotspot analysis results for CI and CFR over a map showing the distribution of SVI across US counties in a purple color ramp. From an initial glance, we can see that darker areas corresponding to higher vulnerability tend to overlap more with CFR hotspots than CI hotspots. Our first main result is that we found that counties in the lowest SVI quintile had significantly greater odds of being in a CI hotspot compared to all other counties, ranging from 56 to 120%. Conversely, counties in the top SVI quintile had 63% greater odds of being in a CFR hotspot than counties in the lowest quintile. Now for the discussion. In this study, we describe a negative relationship between SVI and CI, but a positive relationship between SVI and CFR. We propose that lower vulnerability is associated with factors that facilitate transmission, including the ability to travel more frequently and a tendency to engage in more social events like parties and group meals. On the other hand, residents of counties with high SVI may experience greater prevalence of chronic health conditions that have been identified as comorbidities, increasing the risk of mortality following infection, including cancer, respiratory illness, cardiovascular illness, and diabetes. Those residents also likely have less access to health care, especially the sophisticated medical care that is often required to mitigate severe and mortal COVID-19 outcomes. This study validates the use of SVI in current vaccine distribution policy. We recommend further application of SVI in vaccine distribution in tandem with other factors, such as race and age, to address the structural racism, class domination, and other injustices that enforce gaps in health equity. We also urge key decision makers in public policy to use metrics like the SVI in prioritizing programs for COVID-19 recovery, which should entail behavioral healthcare access, neighborhood economic development, and direct reparations to those harmed by historical traumas and injustices, including people who are Black and or Indigenous. Thank you for your time and attention.